neck veins, you see that it's maybe a little bit distended, and you go down and you hear the heart sounds, you hear murmur, what maqlas al murmur, and then you go to the lungs. Marka lungs, you hear a lot of not normal lung sounds. Different countries call different names, but you know that there's crackles, there's a lot of different lung sounds there. You check the abdomen, his abdomen is soft, and you hear the abdominal sounds. But and then you and you do just a quick neurology, everything is all right there. And then you do an ECG. I hope all of us have ECG in the clinic. And then when you see the ECG, you see it's a sinus rhythm, somehow a sinus rhythm, and the axis is normal. But what you see is the QRS complex, but it's narrow, which is good. If it's wide, then you have to think of different kinds of branch blocks. But then you see if you see the V4 and V5 and V6, the T is inverted. Normally the T should be upright. So the T is inverted in V5, V4, V5, V6. And then you check, and one leads one and leads AVL. I is inverted. That waxay ku tusaa inuu yahay some kind of abnormal ECG. So and it will show you that this is ischemia. You do that. So what do you think is wrong with the patient? So you have done your physical examination, you asked the patient his symptoms, you know his symptoms. What do you think what do you think is your hypothesis, your working diagnosis? Is it because he's hypertensive? Does he have hypertension disease? Is that the problem? Problem كمكاسبة مثلا pneumonia ويان, because he told you his صاحب كيسبة قفيع شري, and maybe that's the problem. Or because cigar بدن بعب شري, it could be a chronic obstructive lung disease, and that's probably superimposed with infection. So it could be heart failure. Or maybe he has a panic attack. So you think about that, and then what's your next step? Would you give the patient antibiotic and send him home, and maybe tell him to come back if he doesn't feel well, and you think the diagnosis, or okay, this is because you have high blood pressure, or you have واحد لهذا ديكر وقت بدل مركا. I will give you antihypertensive medication, and you will see you'll be better. Or you will treat him as maybe asthma, because you hear some kind of asthmatic sounds in the lungs, and you want to treat him for a chronic obstructive lung disease with antibiotics. And if he doesn't get well, maybe you send him to the hospital after some days. Or the last option is you think that this patient is really needs an urgent care. يعني بدبادس بو بهاي لأن his symptoms وكسي درسا مركو ولا أفر بلاد كهر وسعون شد عادي نفط عيلي بكو هذا ممكن هذا، لكن أصلا ما بس يحنكره ما بشيف سنكره. So حالة دي سأد بحنتها هاي and I think بعضهم مالين سإنه له heart failure, and if I don't send him then again كنوا لقي يابي إنه نفط بستاكتو لقي يابي إنه با respiration failure كده، لأن حتى با he has a high respiration rate. So you want to send him to the local hospital for urgent care. You have these options, okay? And then we will come back. I will start with my lecture, and we will come back later what the right answers are. Now, just to give you basics, the heart, you have the right side of the heart, and then you have the left side of the heart. So the right side of the heart is usually low pressure. يعني say وحوي باركي channel وميل وبس بيها لغوصو قبيو from the deoxygenated blood أيا كإمانية the body والغو قبيا دين على right side, and right side وجود بنيا بس. So شقاد right side ما يكون فكرتين basically collect blood. It has low pressure. That's the function of the right side, to just collect deoxygenated blood from the body, from the chirka, and give it to the lungs to be oxygenated, and then give it for the left side of the heart, which is the high pressure chamber. The left side of the heart is very thick. The pressure, because the job of the left side of the heart is to pump blood to the rest of the organs. So my topic will be left side heart failure, because all the metabolic diseases, all the diseases of cardiovascular disease will affects the left side of the heart. And if the right side of the heart fails, is usually because the left side of the heart you have problem with the left side of the heart. So our focus waxay noqonaysaa the left side, and that's where all the dhiigkarku, diabetes, all the kind of cardiovascular diseases affects the left side of the heart. So when it comes to heart failure, basically a left side of heart failure, you divide it into two parts. And one part is systolic heart failure. وهو muruqa ayaa ضعيف noqday. Maybe because it could be a heart attack, and you lost some muscles of the left side of the heart. So ضعيف ونقضي ديجي من ريحست ديجي ayaa ضعيف noqday. And it's this ممكن ديجي systolis ممكن ديجي ريحة ويا that's the failure. And we judge it because the ejection fraction. What ejection fraction is? In echocardiography, ejection fraction the amount of blood into blood, or every heartbeat, the amount of blood that is pumped out to the organs. Usually is amount of blood pumped out usually around 55%. Although 50% of the blood you have to pump to the blood. That's normal. Ejection fraction over 50%, over 55% is normal. So when you have systolic heart failure, then you have low ejection fraction, usually under 40%. So that's the definition of systolic heart failure, is ejection fraction كيبقى add and it's lower than 40%. That's the first, and that's the most common form of heart failure. The other form of heart failure is you don't have problem with hidisty, but the murqi it became very stiff. dabcinaansaydi ayaa adkaaday. So buuxistii inaad left ventricle inaad wadnaha inaad buuxisto ayaa stiff noqdo u adkaaday. So markuu stiff noqdo, the pressure increases. So you can't fill blood with it because it's very thick. And the amount of blood that inaad gelinaysa ayaa yaraanaya markaa. So that's the different type of heart failure. You as a general practitioner, symptoms are the same. Which type of heart failure? That's no problem. That's the cardiologist. That's the only way you can know which type. Echocardiography. But as a general practitioner, you should know the symptoms of heart failure. You should because early recognition will give you your patient has better prognosis. You have pneumonia and you send him, probably because he's going to have respiration failure or kidney failure. As a general practitioner, you should know very well the signs and symptoms and the risk factors leading to heart failure. Best two different types of heart failure, which is usually you will see it after you do echocardiography. Both heart failure with reduced ejection fraction or heart failure with preserved AF preserved are 50-50%. The only difference is that heart failure with preserved stiff heart, it's very difficult to diagnose. You have to have an echocardiography, and you have to it's, how can I say, exclusion diagnosis. You have to exclude other types of cardiomyopathy, other types of heart diseases that can cause the heart to be very stiff. So you cannot give a patient heart failure of preserved ejection fraction before you have exclude other diseases. But the heart failure with reduced low ejection, that's very easy because the ejection fraction is reduced. Now, okay, فشل كوضنها. What is it? It's really the end stage. وحالة ugu dambeysa, if you don't control all the cardiovascular diseases, if you don't control your patient's hypertension, if you don't control diabetes, if you don't control arteriosclerosis, which leads to coronary artery disease, if you don't listen to the heart of the patient, and you don't send a patient when you hear a heart murmur, then it will end up with heart failure. So حالة دونين وحالة أنا دونين إنه patient كانوا قالوا حالة heart failure is one of the last end stage معناتها after that probably patient will prognosis was very bad prognosis. مركا all the diseases I have mentioned حتى أنا كنت سيو all of them will give the end stage of okay. Now, how are the symptoms of heart failure developed? Now, to understand the symptoms is very important. You know, what happens is that wadnahu markuu riixistiisa hoos u dhacdo, the blood starts to dhiiga ayaa isku ururaya. Cadaadis badan buu left ventricle ayaa ku dhacaya, and that causes stagnation or congestion. So you have failure of forward flow, then congestion, but عدادس ka badan your pressure ka badan, backward flow leukemia. The pressure goes backward, and that means that if the pressure in the vessels, in the vessels, the pressure is high, dhiiggii wuxuu kala baxayaa outside extra vessels. Marka dhiiggii wuxuu imanayaa inside the lungs ayuu imanayaa. So inside the lungs, out of the pressure inside the vessel somehow. The pressure is very high because there's congestion, because they give us but then the fluid interstitium. Markuu yimaado sambabaha biyo badan baa soo gelaya interstitium. Oxygen-kii exchange-kii baa xumaanaya. Plus, the lymphatic system extra fluid coming in the interstitium, lymphatic overload bakudaya. Then you will have pleural effusion. You will have pleural effusion in the lungs. So that's the reason, because there's high pressure, congestion. That congestion will go back into the right side. The right side has very low pressure. So any change pressure in the left heart, it will automatically go back to the right side, because the right side has a low pressure. It cannot tolerate high pressure. Marka waxa dhacaya congestion of beerka xataa biyo badan ka buuxsamaya. Kaliyaha fashilka ba ku dhacmaya, because all of the pressure, all of the bihi, aya congestion of the kaliyaha noqonaya. حتى caloosha ayaa congestion gelaya, marka cunto xumid waa ku imanaysa, and lugahana way ku bararayaan. The same reason, there's a high pressure is inside the vessels, because of the congestion, dhiigga isku ururay, then the blood will go outside of the vessels and around the connective tissue, interstitium ayuu ka buuxsamaya. Qofkaas markaas waxaa dareemaysa inuu kugu kordhay wasni badan ayaa kugu kordhaya. That's the reason you have these symptoms of heart failure. So you know why you have neft kugu dhegaysa, because you have a lot of fluid in your lungs. Wuxuu ku bararayaa luguhu, because you have a lot of fluid, there's congestion, dhiigga isku ururay, there's no forward flow. And you waxaad daal badan baa dareemaysaa, because there is no the blood is the left side of the heart is not pumping blood into different organs. So you're not able to get oxygen to your muscles, so that you have lack of energy. Habeenkii bana ugu daran. Sababta habeenkii ugu daran tahay is because when you markaad jiifsatid, all the fluid in your legs legs ayaa soo noqonaya. Wuxuu ku soo noqonaya the right side of the heart, marka daqd weyn, but daqdigii ayaa sii kordhaya marka, because there is no forward flow, and now there's a lot of fluid coming back from the legs. And there is no because dakhli markuu sii bato biyihii baa kasii badanaya neeftii baa sii kordhaysa and most patients waxay doonayaan inay fadhiistaan because lugaha markay hoos u dhigaan all the blood will go back, all the fluid will go back to the legs because of the gravity soo maaha marka badanaa amba waxay ku dhahayaan barkin baan doonay 3 barkin baa ku seexda amba anoo fadhiyaan seexda because they cannot sit they cannot lie flat ma jiifsan karaan caloosha xataa waxaa dareemaysa inuu ku burburan tahay you know buufis baa dareemaysaa and loss of appetite qufaca badan waxa weeye because when you have lot of fluid fluid around the airways irritation ba ku sameynaysaa waxa dhahay bronchospasm baa noqonaya marka broncho sidii asthma noqonaysaa but we call it asthma cardialis because it's coming from the heart failure waa sidii asthma markaasuu qufac badan habeenkina qufacaysaa you know so it's I understand some general practitioners will mistake it for pneumonia and lakin if you take all the symptoms together horaad ka dareemaysaa this is not asthma this is not pneumonia halkan xataa in Norway the general practitioners don't have ma haystaan baalkii qalab waaweyn you need as a general practitioner to be very good at recognizing symptoms and putting all the symptoms, taking a good clinic history and putting the symptoms together to get the diagnosis. badanaa markay yimaadaan hospitaalka wuxuu yimaadaa asagoo heart failure oo neefta ku dhagan tahay oo isla markaa waxaan u geynaa ICU-ga because he went to his general practitioner buu u tagay wuxuu ku yidhahay pneumonia baad leedahay go and come back asma u qoray asma medication buu siiyey antibiotic buu siiyey go and come back wuu soo noqdaa وكوسون غدا وحمود دريمن فائدة مود دريمن مكا the doctor is not يعني he's not very well يعني he doesn't know symptoms of heart failure مكا هذا نو كعليا so there's a patient delay because the doctor doesn't understand the symptoms of heart failure مركا أصدقوا نفتي مكبح هذا أيو نوع من مركا it's very sad مركا it's not a problem حتى يعني where you live it's you have to know the signs and symptoms of heart failure because it will improve the prognosis of the patient. Marka hakan hada way dhacda. Marka you have to very important to have clinical history take time to and you know in a physical examination and the clinic history is very important. Okay. Now just to make it more interesting this signs of symptoms heart failure waxa sheegay long time ago 1000 years ago Ibn Sina wa alam Islami he wrote a book قانون في الطب and that book was used for 600 years both in the east and the west Muslimin they are the pioneers of medicine like this information is not there but I want to let you know that he described the heart failure symptoms heart failure symptoms suffocation your palpitation your syncope he's the founder of a holistic prevention of diseases prevention of diseases not just giving the one I've seen is like in a psychological in a spiritual in a diet a lot of things different dimensions of preventing diseases. This is just to let you know. Okay, hadaba, what happens when the heart fails? What happens to the other organs? Your heart is not doing its job. The heart is not pumping enough blood. There's no blood going to the enough blood going to the brain, to the kidneys. What happens to the other organs? How do they react? Well, how do they react? The brain is not getting enough blood. Somehow, the patient will be anxious. So if the blood is in a heart failure situation, شركة ده وحكون نقنية survival بوجليا survival mood بوجليا مركا survival state بوجليا so you have the nervous system activation لو سميناها sympathetic system كي أيقروا كعيا and why because they want to increase the blood pressure they want to increase the function heart كي وضعيف نقطة أيدونيا إن يقروا كعيان لكن هارد وضنيه تعبانة هذا كوسي ودفتت هذا كوسي برشة سي سارته وسي حمانة يعني سماها لكن this is a survival this is the expected response because the sympathetic nervous system is activated maxay samaysaa? It will give you tachycardia, it will give you vasoconstriction, it will increase hormones like noradrenaline, kuwaas bay kor u kicinaysaa. xaaladda the body is trying to stabilize, but this response is making the heart worse. However, the kidneys also, they activate their own system. They activate the renin-angiotensin-aldosterone system weeyaan. That wuxuu sameeyaa they convert angiotensin 1 to angiotensin 2 vasoconstriction buu sameeyaa. Fahantay? So when you do vasoconstriction waxaa samaysaa daqdigii baa kor kicinaysaa. If aad daqd kor kicisid, the heart is already daciif weeyaan. Marka wadnuhu ma karayo inuu shaqeeyo asagoo daqdi weyn kasoo horjeedo. haddana aldosterone kidney waxay sii daysaa hormoonkooda aldosterone. kaas muxuu sameeyaa cusbadii salt ayuu haysanayaa iyo xataa water retention, xataa biyihii kaadidu kaa yareynaya xataa leanna wuxuu doonaya inuu blood pressure kor u qaado. So this is a survival response of the organs. it will increase a little bit shaqada wadnaha ay ku qasbaysaa inuu in yar kor u qaado shaqadiisa, laakiin kuwaas ayaa dilaya wadnaha kasii daraysaa markaa. So this patient needs help. So these are the responses, and the treatment the treatment is to just to go against these two responses, to block these two responses. That's the treatment. And I had to idin sheegi doona. Now, okay, waxaan kuu sheegay what heart failure. You have two types of heart failure. Heart failure with reduced systolic heart failure and diastolic heart failure. And I told you about the symptoms and how they develop. SAHA. Now, as general practitioner, you ask me, okay, I know this. Why should I know? Why should I know about heart failure? Why? Because honestly, heart failure waxa weeye epidemic uu soo noqonay hadda. And heart failure, at least 64 million people adduunka ayaa ku nool heart failure. And heart failure was a deadly disease actually with high mortality. And almost 50% dadka heart failure within 5 years were dhintaan. And even when you treat heart failure, hadda dawaysiis waa cudur soconaya un. So maaha cudur saa u istaagaya. And even if you give him optimal treatment, most of the patients will continue way sii soconayaan, way sii xumaanayaan. Marka, and it's very expensive. To treat heart failure, really, it's a very expensive. Hadda Norway, and in 2018, Norway $5 billion ayay ku bixisay just to treat heart failure patient. So 5 billion is a lot of money. The GDP of Somaliland in 2019 was almost 3 billion. And Norway used 5 billion just to treat heart failure. So Somaliland doesn't have any resources to treat its heart failure patient. So this disease is very expensive. And not only that, inta basmaha dadka oo cumrigooda yar yahay ayaa ku dhacdaa in developing countries, where in Norway most of them are 70 years old. waa pensionist weeyaan, waa pension ku jira. Can you hear me? ma la maqlayaa? Hello, ma la maqlayaa?
Ha, waa ku maqlaynaa. Ha, what?
Okay, thank you. Marka, the only way we can do is really waxa weeyaan ka soo hortagana this disease, which is very costly. This disease, which is cudur very expensive.
Dr. Mahad.
Very expensive disease. Waxa weeye bahalkii and is deadly. The only is to prevent. We try our best, and that's what SAHA group are doing to prevent those deadly cardiovascular disease. Now you ask me how to prevent. I'm in Somaliland. How can I prevent? Yeah, you can do what you find is what's the cause of heart failure in where you live. So this article shows you what's the most cause of heart failure in sub-Saharan Africa, or Africa badana yani. Hypertension. Dhiigkarka is the killer. Wallahi, I don't understand, but that's one of the 43% of heart failure in sub-Saharan Africa, including Somaliland, is hypertension. A very easy disease to really laga hor yimaado on la daweeyo, And the other one is rheumatic heart disease. Another disease which is very simple to treat was infection of the sore throat, and it's not treated, and the young patient die of heart failure. And the third one is ischemic heart diseases, which is number one in the developed countries. So 70% of heart failure causes are preventable, and sadly dadkeena waxay u dhintaan preventable diseases, preventable causes. It's sad in one waa lagu xum yahay, laakiin haddana it's kind of like we are lucky because we can do something about it. These diseases can be done something. You can't prevent hypertension. You can't rheumatic heart disease. Ischemic heart diseases. When it comes to cardiomyopathy, cardiomyopathy is a little more complicated. Cardiomyopathy, it could be genetic, it could be viral, it could be so it's an individual disease. Lakin preventable diseases, 70%, we can do a lot about it to prevent heart failure. Now, this is an article 30 years, it's comparing heart failure patients in the developed countries like in USA, like in Norway, like in Sweden, UK, to less developed countries like Somaliland or Africa or Asian countries. The type of heart failure patient. So I didn't say average heart age of heart failure patient in the West is 70-year-old. Right? In Somaliland or another developed, the average age of a heart failure patient, he's 35 till 60, the best years of his life. The best years where he is very resourceful. So it's an economic loss, a big economic loss for the country, and also imagine abo or مسؤول 3-4 families, or he has heart failure. So you've lost generally more, dad badan baa dhaawacmaysa. So the average age of a heart failure patient in the developed nations waa qof between 35 to 62, and it's a bad loss. Prevalence high prevalence the amount of people having the disease prevalence here. So there is high prevalence in the West. Why? Because they treat the heart failure with good medication, so they live longer. So the people living longer with the disease is high because they have good health system, and the prevalence is high because as people get older, you have high risk of developing heart failure. Somehow it's because they're aging, because they have good system, they're aging and they're getting more heart failure, not because. But in our we have a lot of people having heart failure because we don't have good primary care, because we don't have inadequate resources, and also lack on emphasis of prevention of heart failure. And sadly, the other part is we are adopting in a lifestyle of the Western lifestyle. That's another one. This article shows so. And incidence was stable. معناتها the new cases of heart failure in the West or developed rich man's country is stable. Our incidence is very high because we don't prevent the risk factors. We don't have a good health system. We don't have good health practice. So a lot of patients are getting heart failure. So the incidence, new cases is increasing. So that's the basic difference between heart failure in developed countries and in developing nations. Now, if you go, heart failure, it's not something that some cases, of course, there are cases where there is genetic disease and it happens because you have genetic disease in your family, or because you have some kind of viral infection, or because, it could be a cardiomyopathy. That's different. But most of the heart failure is not because of this. Most of the heart failure is because of cardiovascular diseases. and cardiovascular diseases وقت بيقاطعن. So stage 0 is قف ممكن وحبة لهين when he is عذرا لهين, he doesn't have risk factor, he doesn't have symptoms. Stage A is وقف أو سيجار عبية أم وقف أو ديكر له أم وقف أو diabetes له. So he has no symptoms in stage A, but he has risk factors. سماها تاسع stage A. Now stage B وكسيدر هذانا, he had risk factors, hypertension let's say, or cigarette smoking or hyperlipidemia or whatever, and then you see that he has organ injury. You take an ECG and you see he has hypertrophy. You take urine sample and he has proteinuria. That means there is some kind of renal damage. So not only now he has risk factors, but he has organ damage also. So he is مرحلة كلو مري هذا تشوشين ويد هذا قبل ويد, he will go to stage C, which is the case. Our patient, he has symptoms. حالات أدو أتكاتل. Now he has symptoms because you didn't do anything in stage 0 A and B. Now he stage C. Now he had failure. يقيم هذا أصل قبا لو هي براري نفط يكون دكتي ما بس يحنكر ما تشيف سنكر وحمس سمينكر ما. That's the stage. Now the organs are failing. If the heart fails, other organs will definitely fail. Now is the worst case. Now is مركو بدباديستي حنتهاي مركو قاري نقطة إن كسميسين مركو this is the stage you don't want to be, stage C. And stage C is that. Stage D is that medication doesn't work at all. Now you have to think, am I going to give him transplantation? Am I going to transplantation? I'm going to put him into left ventricular device من دحق لنا سان أصيب بدبان into كهل يبارك organ donation. So stage D is like أمبو حدا يوسكدني أو يلا توكل على الله اسكدمو دوين يراسين يا سان أصيحيو. Do you understand? So so that's the different stages. So there is a chance that you could وحبات سمين كرتا. You know, there's the chance you can do intervention. Most of the patients واحد جوجان stage A and stage B يعني. And luckily, most of the patients. But if you do something about it, you can do a lot of stage C, quite fewer patients. So you can do some sort of intervention. Now you see this article, Harkan shows you the survival, right? And down shows you the years, Samaha. But you see the green is when you have healthy person. 0 stage وين healthy person survival, but by this was 100%, right? Stage A was buluga, you know, in year also died 98%. Dark brown was stage B, where he has the risk factors with the organ injury, let's say. Still survival. Like in egg stage C and D, the light brown. But by this dramatically hospital done every year because into the. Do you understand? So stage C heart failure is not good. Mortality, but by this the mortality is very high. Survival is very low. So you don't want patients to go to stage C and D. Okay, as a general practitioner, what can you do in stage 0? What can you do in stage A and B? And stage C is when you were in the hospital. There's nothing much. That's not. But you can follow up after he gets out of the hospital. So let's go to stage 0. These are the risk factors for ischemic heart diseases. My colleague has already talked about the hypertension. So I'm not going to talk about that. I'm going to focus on ischemic heart disease and rheumatic disease. So these are the risk factors that you can really do something about it. High blood pressure, diabetes, lifestyle, no active lifestyle, cholesterol are very high, smoking. Khamrada, we don't do that, so I don't mention that. Okay, this is the healthy person. So you want to, when somebody is healthy, you want to prevent risk factors. So what do? This is the 7 lifestyle of a healthy person with cardiovascular disease, cardiovascular health. 7 things. You advise your patients never to smoke. iyo dietkiisa sunnada waa dietka sunnada bariis iyo baasta waxaa la joojiyo dietka go back to the rasuulku suu cuni jiray go back to the sunnada simple as that natural organic food made in Somaliland go back waxaan laga keenaya banaanka bariiska waxaa that's the cause physical activity simple as that socodka badiya and the weight body mass index it's just the weight make sure your weight is similar to your height yani you make sure your weight is stable weight blood pressure go early you marka noqday 35 years or 40 years old check your blood pressure always go the same thing with cholesterol and your glucose so these are 7 you can focus on those 7 things you'll be fine but look at this and if you do all these seven matrix of lifestyle modification halkan the risk of getting all these cardiovascular disease somehow the green line waxa weeyaan or the blue line waxa weey qof oo ka soo baxay oo sameeyay dietkiisa waa good blood pressure waa good glucose everything see he has a very low chance of developing cardiovascular disease or also developing heart failure comparatively qof wana dan kan lahaynba sigaar iska cabaa waxbuu sameeyay wuxuu doonay sameeyay see the red line every year your risk of getting all these diseases is increasing waxa weey waad ka tagaysaa you are going from every different stages stage hadda waxa joogtaa 0 soo maaha so if you don't do this stage waxaad gelaysaa A somebody with risk factors and we're going to stage A here you go we have a patient with stage A risk factors he has either hypertension diabetes obesity and tobacco so what can you do as a general practitioner you work with your patient and you treat those diseases very well. So many countries in UK and Norway and USA, everybody has general practitioners have their score table where they take the patient's blood pressure, gender, nagba, cholesterol kaga, your smoking, all this information they put in the table. Low risk. It shows you 10-year risk. 10-year risk cardiovascular risk somehow. So low, then you advise the patient, okay, you have to go and just work lifestyle somewhere. Like in Hadu very high, you have to start medications. You advise the patient to change his lifestyle for 1 or 2 months, and he comes back to you, and then he doesn't really have good blood pressure and cholesterol, and glucose. Then you start giving him medication. Yeah, you don't want him to develop organ injury. That's what you don't want to do. Here is the very given and easily given. You just have to follow the table here. So if he is high risk patient, then you should let's say your patient a goal is I want your blood pressure to be 100 under I want your cholesterol to be so in 1 month or in 2 months come back to me in 3 months come back to me he comes back to you the goals are not reached somehow then you have to start you have to give cholesterol medication or treat the hypertension you have to start treating and make new goals with your patient. Make sure that it's optimally treated. You don't want him to go from stage B now to go to stage C. You don't want to go to stage C. Or stage A to stage B. Because that's why you take urine sample. That's why you check the protein in the urine to check if there is injury garden. That's why you take ECG to check if it's artery fibrillation or hypertrophy. That's why you do these things. So as a general practitioner, you make sure that these risk factors are controlled, that he doesn't develop in 5, in 10 years heart failure. That's of course it's but it's very important because you don't want to in a progression okay here look at here the green line is a good patient and a good general practitioner, right? They work together. If you green line down, you see it shows that they work together, and he controls all the risk factors. Here he controls all the risk factors, and he sends his patients to whatever coronary angiography if he complains of chest pain or something like that somehow, and they do intervention, and he succeeds. He has no problem with the heart. He doesn't develop anything, no heart failure. he continues. So he has no risk of death or myocardial infarction. If you see the red dots here, that's a patient who really has not controlled his risk factors. Let me see. Yeah, risk factor is not controlled. So he all of a sudden, a heart attack, myocardial infarction, and he's not controlled. Another myocardial infarction. See, another heart failure, and probably he will die. Well, the green one is still very low. He has very low risk of developing heart failure, risk of developing a heart attack or dying of arrhythmias. So it's very important to, as a patient information, very important to have your patient have information, and the doctor also how to control the risk factors, because in the long term you have 5-10 years time, or you want to prevent the development of heart attack or heart failure. Okay, now that stage C, that's where you don't want to be. That stage C or heart failure. That's survival cover 50%. The cost is very high to treat. There is no cure. You can start that, and we start with secondary prevention. Okay, so the patient comes to our hospital with heart failure. حسب ما نعرف في echocardiography, we see what type of heart failure. Is it heart failure with reduced ejection fraction? Is it heart failure with preserved ejection fraction? And then we have a possible etiology, and we start treating the etiology and treating the heart failure. That's in the hospital. Now, what's the treatment for heart failure of reduced ejection fraction? When a patient comes with heart failure, is full of fluid, 10 kilo, full of fluid overall, you don't start with heart failure medication. You have to give him diuretics. You have to give him diuretics. That's very important. You have to relieve the symptoms. So you cannot start heart failure medication before the patient is decongested. So decongestion is very important. You need to do it, because otherwise you cannot start. You will kill the patient. If you give a patient who has a heart failure, full of fluid, if you give him beta blocker, you're going to kill him. Beta blockers is not meant to be given in the acute phase. Beta blockers is something in the long term. It helps them survive long term. But in acute phase, kafogo beta blockers. But anyway, you start with diuretics. Give him diuretics so that he can breathe better. That's what we do. We give him diuretics. And then afterwards, these are the medications, 4 different types of medication. That's for the treatment of heart failure with reduced ejection fraction. Angiotensin converting enzyme inhibitors, ARNI, mineralocorticoid antagonist, all these, they work the renal angiotensin aldosterone system. This is stress mechanism. And the beta block the sympathetic nervous system or activation. So we want the heart to rest a little bit. Those systems, that the basic treatment is to take those 2 symptoms and give the chance give the heart chance So okay, so these are the 4 pillars of heart failure of reduced ejection fraction. Okay, if we talk about beta blockers, it reduces mortality. Beta blockers were good documentation since the 90s, good documentation, but do not give a patient who has hypervolemia, who's congested, beta blockers. You don't need that. You need it later. Normal volume. When you decongest, then you can start with a very low dose. And always try to they say the highest dose gives the best effect, which is good, but not all patients they cannot tolerate. They have a lot of side effects. And when you want to beta blockers, use these 3. Use bisoprolol, use metoprolol. Why? Because these are the ones with all the studies have been done with these 3. So you can't give atenolol, your propranolol. No, there was no study done on those. So these 3, if you want to give medication, beta blockers to your patient in stable situation, give these 3 And then you see angiotensin converting enzyme inhibitors. There's also good documentation. It reduces, but that 25% in mortality. you know. So it doesn't matter if you use angiotensin receptor blockers and AC inhibitors, vascumin. But I recommend that you use AC inhibitors because most of the studies was done on AC inhibitors. Yeah. But some of the patient واحد hypodermia قفها. If you have your patient قف أو قفع يحرك مركز and you see he's breathing anapril على ramapril على AC hammer, then that is the cause of it. مرة كبدل كرتا وحاول بكر كرتا نوها يعني angiotensin receptor blockers. And ARNI is also recommended, but it's very expensive. So I don't know, يعني it's quite expensive, but it is the one that it has better, in studies, it has better effect than يعني ASA, angiotensin converting enzyme inhibitors. It has better effect. You can do ARNI. ARNI, it contains an extra element, neprilysin, which is it causes vasodilation. It has, I won't go detail into it, but if you use SAHA, that's good enough. But the expense of using ARNI, it is better in 20% reduction, but it's quite expensive. I don't know how. The cost is the problem. Let's say a patient who cannot tolerate masinkated ACE-HAB angiotensin receptor antagonist masinkated, then you can give hydrolysine, especially in America. Those they respond well with hydrolysine denitrate. Now the third one is mineralocorticoid antagonist. It's just aldosterone antagonist. Same. With studies, it shows good documentation where it decreased mortality between 15 to 30%, But if you have renal failure, which is GFR under 30, it's contraindicated. And always check your potassium level, before you start. Start with very low dose. See if patient can tolerate it or not. The fourth one, which is recommended, is SGL2 inhibitors. Group of diabetic diabetic medication, but it showed in studies it has very good effect with the heart, and it reduces mortality in heart failure patients with 15 to 25%. And لما قرأنا how we don't know the mechanism how it helps the heart لما قرأنا, but it does show possibly it has a diuretic effect and it has a direct effect on the heart myocardium. But we recommend it. But exact mechanism, different mechanism, like exact mechanism, but what's important is this medication markuu qofku xanuunsanayo amba infection leeyahay amba dehydration leeyahay amba markuu soomayo inuuna qaadan weyn leana it will give you diabetic ketoacidosis ayaa ku siinaysa. Possibly those with diabetes, those who don't have diabetes and heart failure, often they will not develop ketoacidosis ma lahaanayaan, laakiin diabetes they have to stop if they have infection or they are dehydrated or they have renal failure. In renal failure also, if GFR is very low, it's contraindicated. Now, basic things with heart failure, as a general practitioner, it's always, we start in the hospital, usually the general practitioner follow up. But this is usually we start in the hospital because you need to know you need to know the kidney function, you need to see the electrolytes. Like always, when you're giving medication or heart failure, go very slow. Start low and go slow, and take every week. You titrate between 1 or 2 weeks. Now it's recommended that you titrate within 6 weeks, but you always, when you're titrating, you have to go low and go slow and check the electrolytes. High dose, aim for high doses because that will get the best benefit. Side effects, then you have to reduce the dose or you have to increase the interval of titration. Instead of increasing the dose every week, try to increase it every 2 weeks. Maybe patient will be better adapted to the medication. And avoid NSAIDs, NSAIDs and heart failure. Okay, I won't go very detailed because this is mainly for cardiologists that you give the 4 medication and he comes back to us. Stage C now, I'm talking about stage C. Actually, it's a cardiologist's job, actually, not a general practitioner's job, Stage C, we do echo, and then we check him again, and we see what is AF. Is AF improved? That's fine. It's not improved, then we know we'll try to find what we can do for him. If it's very low, then we will maybe give him an ECD, which is intercardiac device to prevent arrhythmias, And then if he has some kind of left bundle branch block, that means the heart is really not synchronous pumping. It's going like that. Then possibly we will give him another pacemaker device to give him a sync. But that's a little more advanced. You don't have to know that. Okay, the next one is I talked about ischemic heart diseases, right? And now the next one is very simple. I just go very fast through it. The rheumatic heart disease. The rheumatic heart disease waxa weeyaan very simple disease, honestly. waxa weeye waa throat infection, which is really easily treated with antibiotics. Very easily treated with antibiotics, but because of the delay in treatment, or children go with throat infection over weeks, خلخل baa ku yimaada immune system ka. So the immune system cannot now hadda ma dareemi karto. Is this the protein of the bacteria, or is the protein of the body? Marka it start to attack different organs. So it was an infection disease of the throat. We didn't treat it. It went waxay isku bedeshay baalkii autoimmune disease. And autoimmune disease is isku bedeshay. It's no longer an infection disease. Now it's an autoimmune disease. Khalkhal baa immune system galay. It cannot recognize between the protein bacteria or the protein of the body. So it starts attacking the heart, it starts attacking the joints, it starts attacking the skin, then brain, and then you have different symptoms because of the autoimmune system. The risk factors waxa weeye baalkii, of course, waxa ku dhacdaa ciyaalka yar, teenagers iyo children bay ku dhacdaa, and because parents are not informed, or maybe social workers are not, nurses are not well informed, possibly some general practitioners are not well informed. So this is not, the throat infection is not treated, And we have also, of course, lack of medical care and lack of, health system that also contributes. So you have these major signs. Polyarthritis is one of them. Polyarthritis. You have skin, we have subcutaneous nodules, and you have also erythema marginatum, rash. So you have to know, as general practitioner, these symptoms you have to know, these signs you have to know them, and also you have, because of the antibodies in the brain, they have some kind of abnormal movements, or chorea movements. So these are the major signs. In the heart, the immune system attacks all. It attacks the pericardium, the myocardium, it attacks the valves, and the most it attacks the valves. When it attacks the valves, the valve doesn't function anymore. The valve, it either becomes very thick, but it leaks a lot, both ways, but it will give you heart failure. So you have to know the major signs. So you have the major criteria, when you have polyarthritis, erythema marginatum, when you have subcutaneous nodules. This is very important that you recognize it, because you have to recognize it early. It's very important. And then you have the minor criteria. So you have to recognize these major minor criteria and treat the infection quite fast. The only way to prevent and reduce rheumatic fever is to treat pharyngitis with antibiotics. You have to be the only usually I'm not liberal with antibiotics, but with this one, I think every general practitioner should be liberal with giving antibiotics, because you're preventing a very deadly disease that causes heart failure. It's acute rheumatic fever. So, and it's very important that all the general practitioners are really aware of this disease, and they treat pharyngitis with penicillin liberally يعني. If you have secondary prevention, it means that you have developed secondary prevention. That's primary is to treat to prevent the acute rheumatic fever from occurring. Secondary is you already have the disease. You have diagnosed the disease because you have the major and minor signs. SAHA. Then that means you have to prevent every time a patient gets a rheumatic fever, every reoccurrence destroys the valves. So you want to avoid that. So every month you have to intramuscular penicillin over 10-year duration. That's to prevent rheumatic fever. Okay, and then the other one is just supportive care. This article shows that the prevalence of rheumatic heart disease is very high in East Africa. This article is from Ethiopian article, meta-analysis, you know. And how can you so we have to focus on primary prevention to really educate social workers, teachers, nurses to detect sore infections, right? And also general practitioners. Now we go back to our patient, right? We go back to our patient. He 56. So the main things here, neefta dareemaya 10 kilos in last 4 months, right? Ma seexan karo, ma jiifsan karo, lugaha bararay. So these are the signs of what? Heart failure. And he has a risk factor. You see, he's cigarette smoker. He's already a risk factor. qaadna wuu cunaa. That means qofan haddaan kan lahayn weeyaan. And his lifestyle is damba kamala. Yeah? So what are you going to do? So you checked him out, right? You see everything. So I guess your diagnosis will be now heart failure, right? Your diagnosis will be heart failure. That's what I think. And then what you do, and then you treat him. You don't send him to home and give him antibiotics. No, the guy is look at him. He's tachycardia. His pulse is 100. The saturation is 90%. He's hypoxic. Somaha. He is anxious. So this patient, you shouldn't send him home. Yeah, if you send him home, he will die. Basically, simply. And then,
Dr. Mahar,
yeah.
Please, we are approaching to the prayer time here. So please, you have 5 minutes to conclude, please.
Okay,
And
I'm very
we have
close. Yes, yes, yes. So, so this patient needs urgent care. Send him to hospital, because if you don't send him within 1 or 2 hours, he will be in respiratory failure. Yeah. So the correct answer is heart failure, urgent care, and send him to the hospital. Now, when in the hospital, when you have the hospital, we divide the patients with heart failure. When you see the patient, you have to have in your mind, okay, what kind of patient do I have? Do I have a patient, the normal patient, warm and dry. Warm means he has normal blood pressure. Dry means he is not congested, right? So our patient is warm, maybe because his blood pressure is 160. So he's warm. He is not cold. If he's cold, he's in shock. So my patient is warm, and he is wet because he has fluid everywhere. In the lungs, he has fluid. Samaha, his lungs. And so he is warm and he is wet. Now I know where to put him. Now I know how to treat this patient, because when he's warm and wet, I need to give him a lot of diuretics. I need to put his blood pressure a little bit down. Samaha. If he is cold and wet, when he's cold and wet, when the blood pressure is very low and he is over hydrated, a lot of fluid in different organs, that's a cardiogenic shock. That's the worst case scenario, you know. So in this patient, he's not in the worst case scenario. So what I want to do is, you can see warm and wet, that's down here. So what you want to do is, you have to give diuretics. You have to transport the patient to ICU. You give him diuretics. You have blood pressure, and you try to put the blood pressure down by giving vasodilators. And if we have non-invasive ventilation also, So that's the treatment for acute stabilizing treatment. After that, so in this patient, he has an acute on chronic decompensated heart failure. That's the working diagnosis. And we think possibly he has had an acute coronary syndrome. It's NSTEMI, possibly. And if you do an echo, he will have an heart failure with reduced ejection fraction, possibly ischemic heart failure because his ECG shows ischemia, right? So we have to stabilize this patient, decongest him first, and send him to ICU, give him a double antiplatelet therapy and coronary angiography within 12 to 48 hours. And then after that, we have to optimize his heart failure treatment. He's in stage C, which we don't want to be. Okay, to end it, is that you have to know as general practitioner symptoms and symptoms of heart failure. You have to prevent risk factors, prevent progression to stage C of heart failure, and now you know that hypertension, rheumatic heart diseases, and ischemic heart disease are almost cause 70% of heart failure in sub-Saharan Africa. So you, as a general practitioner, you can do something about it to change that because it's a big economic loss for young patients between 35 and 65 to have heart failure. So it's very important to treat risk factors early in order to control and reverse the trend. That's it for me. Thank you very much. Any questions?
Thank you very much, Dr. Mahad. And runtii waa mashaakilkeena waaweyn buu ka mid yahay heart failure-ka waana arkaysaan sida uu maaragtay uu maaragtay challenging u yahay inaguna ma garanaysaa wax laga yaabaa in dhakhaatiirta aanay practice-ka ku jira aanay maaragtay patientka in sariirta la saaro la examine gareeyo aanay dhaqanka ahayn ama ay aad iyo aad u yar tahay taasina way sii kordhinaysaa in la helo waqti hore runtii patientada heart failure-ka lagu diagnose gareeyo dalkeenu dhammaantood waa dad la sido oo cusbitalka la keenay oo haddii abeedma ay xaaladoodu ay adag tahay dhakhtarku aad iyo aad buu mahadsan yahay haddii ay jiraan hal su'aal ama laba su'aalood runtii dad fara badan baa cawday runtii oo casharka ka faa'iidaysan lahaa qaylada baxaysa qofkii aan doonaynin waa inuu iska baxa weeye ma aha in waxa weeye dadka macquul ma aha inay suuq ay casharka isu bedelo dhakhaatiir badan ayaa fariimo noo soo diray oo ka cabanaya buuqa xagga dambe ka baxaya marka arrintaasi ceeb bay nagu tahay runtii hadduu daalo qofku runtii waxa ay tahay inuu yar baxo inuu soo warwareego haddii uu focusku maaragtay ka yar waxaysmo laakiin sheeko lama ogola qof kasta oon magaciisa qorinna ha qoro magaciisa laanno ha dhowto shahaadada ma helayo qof kasta magaciisa iyo saddexan waa inuu qoro kaadhadhka markaad sii baxaysaan miiska aad sii saartaan haddii ay beedmo insha allah intaynaan salaada u bixin miyay jirtaa qof su'aal qaba oo weydiinaya doctor mahad insha allahu taala
Okay.
Okay, and waxay u eg tahay in maaragtay aanay su'aalo badan jirin doctor mahad aad iyo aad buu mahadsan yahay jazakallahu khayr
Allah
insha allahu waxa ay maanta runtii halkaa inoogu dhammaaday maalintii koobaad dhammaan dadka ka soo qayb galay aad iyo aad bay u mahadsan yihiin mooyaane kuwii buuqayay uma mahad celin karno runtii laakiin waxaan rajaynaynaa berri inaan idiin mahad celinno haddii aa aamustaan insha allahu tacaala qofkii qalin u baahan qofkii buug u baahan waan siinaynaa dadkaan magacyadooda qorin ha qoraan insha allahu kaadhadhka halkan ha la sii dhigo berri subaxa 8 subaxnimo aan nimaadno toobikyo aad iyo aad muhiim u ah ayaynu insha allahu tacaala haa uu ka mid yahay career guidance and pulmonary function test جزاكم الله خير هذه aad ba dhammaantiin mahadsantihiin salaadii baynu qabanaynaa ma sawir fiican berritaynu galaynaa walaal sawirada ها haddii aynu sawir gallo oo halkan ku gallo way fiican tahay cidda tegaysaana ha tagto insha allah ciddii sawir halkan ku galaysaana halkan aynu ku gallo si aynu dhaywanka xusuus uga reebno aad baa u mahadsantihiin dhammaantiin asalaamu calaykum
فضلا انت ربطها انay sawir xasuusa ifanka maanta aan kusoo gabagabaysano xaggan hore ha soo istaagto inta dadka aan isqorina ha yara fadhiyaan waa la qori doonaa hadduu ilaah yidhaahdo sidoo kale banner weyn baa yaala dibadda marka albaabka laga sii baxayo halkaana waxaa loogu talagalay ciddii xiisaynaysaa inay sawira ku geli karto waad mahadsantihiin